हाय सुनील।
हाय अमित।
गुड। मैंने स्लाइड नहीं अभी बनाया है।
अभी तो 3 मिनट बाकी है, आएंगे लोग।
बना लेता हूँ 3 मिनट में। थोड़े से और चेंजेस करने थे।
पानी पी के दो होगा।
आराम से।
अमित, अमित कुछ एक्स्ट्रा नहीं आ रहा है ना वीडियो में?
नहीं नहीं तो ऐसा कहीं कुछ नहीं है।
ठीक है, मैं वही बोला, पता चला कुछ दिख रहा है।
ओके।
बहुत ब्रॉड है ये एप्पल का कैमरा।
हाँ ठीक है, अभी ब्रॉड नहीं है। इट्स ओके।
हम घर चले आए ना।
गुड, अच्छा किए, नेटवर्क अच्छा रहेगा।
वर्चुअल बैकग्राउंड कैसे सेट करते हैं?
आज ही करोगे?
पूछ रहा हूँ, मैंने लास्ट टाइम 2-3 बार किया बट इट वाज नॉट गुड।
वो जो स्टॉप वीडियो लिखा हुआ नीचे आ रहा है ना, वहाँ पे जो एरो है ना, उस पर क्लिक करो, उस पर फिर सारा आ जाएगा डिटेल।
चूज वर्चुअल बैकग्राउंड, राइट? इसमें तो ऐड करना पड़ेगा क्या?
ऐड करना होगा।
कोशिश करते, डाउनलोड करते कुछ।
So, Dr. Amit, I think we can start. The rest will be joining us in a few minutes.
Yeah, that will be fine. I think so. Just so, good evening, everyone. So, in our, I will like to thanks our chairperson first, Dr. BK Mishra sir and Sambasivaiha sir, to agreeing to chair this sessions. And we are, since we are organizing now the symposiums in different organs of the body, and this is in our series. This is the breast symposium, and this is the first part of which, the next part will be after 3 weeks or so. So this symposium will basically going to be dealing about the hormone receptor positive breast cancer and the TNBC and the triple negative breast cancer. These two parts are being going to be dealt in this session, and in which we have a few talks, one by Dr. Anuj Gupta from Varanasi and other by Dr. Akhil Kapoor. And apart from this, we have a mostly the panel discussion, which is based on the advanced TNBC, which will be done by me, and in which we have got panelists from all over India. And the other panel discussion will be done by Dr. Akhil Kapoor, which will be based on the hormone receptor positive breast cancer. So I will request BK Mishra sir to chair the session, and please introduce our first speaker, Dr. Anuj Gupta, for the talk.
So, good evening, all of you. First of the topic is very relevant, that breaking the myths in the breast cancer. And we are going to start with the first lecture by Dr. Anuj Gupta. He is an assistant professor at Tata Memorial Hospital Varanasi. And the first topic is the redefining the standard of care of postmenopausal hormone receptor HR positive, HER2 negative advanced breast cancer. So this is the very common entity, and over to Dr. Anuj for the starting the topic. Dr. Anuj, please unmute yourself.
Okay. Very good evening, everyone. So. I think the slides are visible to everyone.
Slides are visible, but you need to on your full screen. Yes. Now
Okay.
it's
Very good evening to everyone. I am going to give a brief talk about a well-known molecule which has established itself in hormone positive HER2 negative advanced breast cancer. And if we in this setting now we look for this molecule or one such molecule to be at the part of treatment, as they have established itself in the metastatic setting, and now coming up with the role in the adjuvant setting. So we will look into the some of the data, and this is the disclaimer. The slides are provided by the organizers, and this is the table of content. We will go through the different topics about the we will see a case scenario where such molecule is applicable, and then we will talk about the drug, its guideline, various platforms which have adopted these guidelines, and talk about some data about this molecule, that is hydroxyl. So this is a common situation, although this is a prototype, but we come to patient with a lot of permutation combination, like a patient having example, a patient coming to us who is a 60+ female, which initially present to the local doctors. Then they find a breast lump which is locally advanced on investigation, but when she comes to us, we do a biopsy, get a scan, and found it to be a advanced breast cancer. And when the on IC it is ER/PR positive HER2 negative, then a situation arises that whether we need to give chemotherapy to such patient, or it can be managed by the help of therapy in the terms of hormone therapy or CDK4 directed therapy. And now we have other PIK3 drug targeting PIK3 mutation. So we have to choose between them and plan our treatment. So this is a case situation, and for such situation, the treatment goal are almost similar from the point of patient as well as the treating doctor, that we want to give the patient prolonging his life, as we know that as of now, fourth stage disease or metastatic disease, it is not curable, but the aim is to give to prolong the survival of the patient, and giving the quality of life, not only to prolong the life, but also giving a good quality of life with minimal toxicities as far as possible, and relieving the symptoms which are due to the disease in the primary side as well as in the metastatic side. So these are the various things which we keep in mind when deciding a treatment, and these are the same thing which a patient have expect from a doctor while giving a treatment. So this is algorithm which we go through in such a situation. The first line of treatment is either hormone therapy in form of tamoxifen or aromatase inhibitor. And if the patient is not getting CDK4/6 inhibitor, then we give this therapy, add with this therapy in the second line of therapy, as a second line of therapy with either the fulvestrant, or if you are or if we are not given AI in the first line, then we can add with the AI or tamoxifen. And if the disease progresses on second line, then we have options of chemotherapy or exemestane and everolimus. And with the PIK3 mutation testing coming in, and with the availability of the drug targeting it, we can have third line of treatment in the form of that also. So in the different guidelines which we follow, mostly as in the NCCN, ESMO and ESCO, all the three, all the guidelines, standard guidelines mention the use of CDK4/6 inhibitor in combination with AI in the first line of treatment for ER/PR positive and HER2 negative patient, as we have seen that these drugs have increased the median PFS as well as achieved a greater overall response rate. And now we also have a prolonging of the overall survival with a couple of these drugs, which we'll look into the further slides. So talking about the CDK4/6 inhibitor, this is a very important slide to know, because we have learned the tumorogenesis in our academics while our training, that we know that CDK4/6 is a key role in the tumorogenesis in the breast cancer, in the estrogen pathway. Later in the downstream signal, we know that when there is cyclin D combines with CDK6 and 4, there is phosphorylation of retinoblastoma gene, and further they upregulate the cell cycle, leading into the tumor proliferation. But it is important to know that the level of CDK4/6 upregulation is more important than CDK6 in this breast cancer cell lines, and targeting a CD4 inhibition is of more utility, and we should try to emphasize on the drug which has a better CDK4 inhibition, which will give a better control in the disease in the metastatic setting. So the targeting that CDK4 cell drugs which are available to penetrate the tumor cell, bind to and inhibit CDK4 are the things which we should look for in such patients. So this is the slide which I was which depicts the role of or pathway of the CDK4, how the this estrogen receptor activation upregulates the cyclin D and its production and attachment to the CDK6 and 4 further enhance the cell cycle proliferation and the tumorogenesis. And by selectively inhibiting this CDK4/6, especially the CDK4, we can arrest the cell cycle in the G1 phase, and thus reducing the cell viability and leading to tumor shrinkage. So treatment decision again, to summarize, we can know this is the common funda in the treatment of any cancer, that the treatment decision depends on the stage of the cancer. Similar is the case with breast cancer. It depends on the stage. What lines of treatment the patient have received in the previous in the past, whether the patient has progressed from after receiving adjuvant therapy, or the patient is de novo, and if the patient has achieved previous lines of therapy in the form of adjuvant therapy, whether the patient has progressed on treatment on hormone therapy or after the stopping chemotherapy. So that will decide whether what type of treatment we need to take. Also, patient related factors like the whether the patient is premenopausal, postmenopausal, how was the tolerability of the patients for the previous line of therapy, what is the patient preference, and what is his or her pocket allows to take. These are the factors which also is to be considered while taking a decision about the treatment. So we have around 3 CDK4/6 inhibitor available for the decision making, and we know all of these have shown in multiple trials the increase in overall response rate, improvement in the PFS, and improvement in the clinical benefit rates in when combined with the endocrine therapy compared to the endocrine therapy alone in this setting. So to summarize, this is a very good table formulated, giving some important data about the trial, about the drug for the palbociclib, ribociclib, and abemaciclib, that is Paloma, Mona Lisa, and Monarch 2, 3, and Mona Lisa 7. And we know that all the 3 drugs have shown a very good hazard ratio of around 0.56 to 0.6 in all the trials, and the median PFS has also improved in the tune of around 10 to 13 months with the various drugs when compared to the endocrine therapy alone, and overall response has also increased from around 30 to 40 with the endocrine therapy alone to around 52 to 60% in the combination arm with the CDK4/6 inhibitor. So we can see that all the 3 drugs have definitely given a very good options in terms of PFS and overall response rate and hazard ratio. But what we aim is to get a better overall survival with our patients, and so it becomes easy to select when we look into this chart about the overall survival, and we can see that ribociclib overhand have upper hand with compared to abemaciclib and palbociclib when we look at the overall survival data, and ribociclib in all the 3 trials, that is Mona Lisa 2, Mona Lisa 3, and Mona Lisa 7, has shown a significant overall benefit. In Mona Lisa 2, after a median follow-up of around 6.6 years, the PFS, the overall survival has increased from 51 to around 64 months with a hazard ratio of 0.6. And in Mona Lisa 3, again we can see that the combination of ribociclib with fulvestrant. Fulvestrant was the partner in this Mona Lisa 3, and this again have shown the improvement in overall survival from around 51.81 to around 70% or 68% in Mona Lisa 3. And Mona Lisa 7, which include the premenopausal and postmenopausal both patient, and the partner was again aromatase inhibitor. In this, after a median follow-up of around 4.5 years, we have a median overall survival of around 58 months for the combination of compared to the 48 months for the placebo arm. So we can see that all the 3 trials have shown benefit in the in terms of oral survival. We have abemaciclib, which has also shown improvement in the overall survival in Monarch 2, but data from Monarch 3 is pending. But the palbociclib data, which was again presented in this ESCO also, have not shown any benefit in the overall survival, although the PFS data is good for palbociclib, but it failed to show any significant overall survival with this drug. So talking about Mona Lisa 2, which is the largest first-line study in the postmenopausal women. Again, to summarize, the PFS benefit was shown in this trial with the median PFS around 53 months in the combination of compared to 16 months in the hormone therapy alone arm. If we talk about overall survival, we can say, as I have already discussed, that there was improvement of around 12.5 months in the 12.5 months in the overall survival, and the overall survival increased from 51.4 months to 63.9 months. And also there was 24% reduction in the risk of death, that was hazard ratio of around 0.676. So this is a very interesting chart, and it shows that the benefit of ribociclib is maintained over the time period, and we can see that at the end of 48 months, the difference in the survival in the patient who are taking combination compared to hormone therapy was around 5.7%, and with the as the time progressed, that means when the patient continued taking treatment, the ribociclib patient continued to maintain the response, but the hormone therapy lost their response, and this difference was increased to around 12.2% at the end of 72 months. So we can see that the ribociclib gave a quick response, and the response is maintained when the patient gets a response to this therapy. We have seen the overall response in a wide variety of subsets. Almost all the subsets have shown a very good increase in overall response rate, significant improvement in overall response rate, whether the patient was de novo or the patient have received previous treatment, depending on the number of metastatic sites, whether there was fewer sites were there, or the patient have the disease burden was high. All the patients have shown a very good improvement in the overall survival. So this is this graph shows the median time to initiation of chemotherapy after the treatment with ribociclib, and again we can see that the patient who were treated with ribociclib have better chemotherapy free interval, and it was again the difference was by around 12 months for the patient who were taking ribociclib in combination with the hormone therapy. So in one study which was published in 2020, the percentage of tumor response was categorized by the author into the patient having a very good greatest decrease in tumor size, and to the lowest decrease, and they have categorized the patient into 4 categories. Group 1 having the maximum response, as group 4 having the lowest response, and this study was done after the initiation of treatment, after the 8 weeks of the initiation of treatment, and it was shown that the maximum benefit, the patient having the greater decrease in tumor size were the patient having more of the patient were on the ribociclib arm. So not in the only in the terms of sustained response, but the reducing the bulk of disease or reducing the burden of disease was also improved much greater in the patient who were receiving the combination. Talking about the continuity of the treatment at the end of around 70 months in the Mona Lisa 2 trial, around 30 patients were still continuing the treatment compared to 17% of the patient in the hormone therapy alone. This shows about the safety or the toxicity profile of the combination and the Mona Lisa 2, and we can see that the grade 3 and 4 toxicity was present in in the ribociclib arm, but they were easily manageable and they were not life-threatening, apart from certain patients having neutropenia, which was around 77% more in the ribociclib arm compared to the placebo arm, and others minor side effect which we are not able to make and patient complaint like nausea, fatigue, anemia, headache, arthralgia. They were seen in both the arms, but their incidence was not that alarming. And the toxicities were fairly managed. And we have also seen in our clinical practice that ribociclib is the safety of is quite good, and we hardly see any alarming side effect in our patients, although there is documented or side effect of QTC prolongation, but we have not seen any such major QTC prolongation. We see that the QTC is prolonged, but if we interrupt the treatment for around 1 week, then this can easily be managed. As again in this slide we can see the comparison between the 3 molecule, and we as already discussed that CDK4 inhibition is important for targeting this set of patients. And again ribociclib has shown better inhibition of CDK4 compared to CDK6 when compared to the abemaciclib and palbociclib. In fact, the ribociclib was 8 times more having preferential inhibition to CDK4 inhibitors, CDK4 compared to placebo palbociclib, and again when compared to abemaciclib, it was more with the ribociclib. Free drug concentration was also achieved much more in the ribociclib. And talking about the major safety concern, the QTC prolongation, which has been a concern, is hardly noted. However, those with the abemaciclib and palbociclib, the diarrhea and hematological toxicities can be routinely seen in our clinical practice. So that about the case, which was a hypothetical case, again we know based on our discussion that ribociclib combined with endocrine therapy is the only first-line treatment with longer OS benefit. It is a preferred treatment option for hormone receptor positive HER2 negative breast cancer, and it has shown consistent or benefit regardless of the endocrine therapy line of therapy and menopausal status. So again, to summarize, this molecule gave a longest reported median overall survival, has a longer delay in time to chemotherapy, have better improvement and preservation of quality of life, and established safety. So we all know that we have discussed about ribociclib, but we all know that abemaciclib and the palbociclib have their own advantage when compared in certain settings, and that should be kept in mind while deciding the treatment and while choosing about the CDK4 inhibitor in the certain settings. So with this, I'll end my talk and hand over back to our respected chairperson.
So thank you, Dr. Anuj. And I think in interest of time, we will go to the panel discussion. And the panel discussion, the topic is the management of the advanced TNBC. And moderator is none other than Dr. Amit Kumar from Medanta, Patna. And panelists are Dr. Rajit Khanna, Delhi, Dr. Nagen Sharma, Medanta, Gundgaon, Dr. Sunil Chopade, Prince Ali Khan Hospital, Mumbai, and Dr. Saurabh Mishra from AIIMS, Bhubaneswar. So over to Dr. Amit for the panel discussion.
Thank you, sir. Thank you for the kind introduction. So, without wasting time, I'll just get through the panel discussion. And in my panel, as it's already informed, we have Dr. Raji Chana from Dharamshila Hospital, Delhi, Dr. Nagendra Sharma from Medanta Hospital, Gurgaon, Dr. Sunil Chopade from Prince Ali Khan Hospital, Mumbai, and Dr. Sujay Srinivas from TMH Mumbai. So just before starting the session, I'll get back to the molecular classification. That is what we get either by the DNA or RNA sequencing. That is the subtype 1, 2, 3, 4, which is luminar androgen receptor or mesenchymal or basal-like immune suppressed or immune activity, or that what we get by the gene expression profiling, the 6 classification, which we just like basal-like 2, immunomodulatory, mesenchymal, stem cell-like, or luminal androgen receptor. So I will like to start the discussion with this only. My first question will be to Dr. Rajat. Sir, are you doing molecular profile in any of your patients? Does it have any significance at present?
Yeah, so I don't think that as of now we are doing it. Because there are no provisions to get it done, but I think this is definitely the future because TNBC is not a very good biology disease. So we know that if the TNBC patient, if they survive the first 3 years, then probably the survival is the best. But we need to identify those patients. So as of now, I am not doing, but in future, maybe yes.
Thank you, sir. My question will be to Dr. Nagendra. So, Dr. Nagendra, you are working at the most premier institute of India with the most affordable patients. So, in any patients, are you planning to do these types of testing? Are you doing in any cases?
Right. As far as the advances in oncology is concerned, we always are updated. We always trying to tell and explain the patient tendons who are responsible that this is the way the biology is advancing. But right now, as of now, this is premature. Yet theoretically, yes, it is important for us to know. But I think it has not yet come to the pen of the doctors. In probably in near future, I think we are going to discuss this more in the tumor boards, and we are going to take this discussion in the OPDs, and we can take decision based on this report also. We know that the patient like will not do well. All those things are there, but as far as of now is concerned, I think we are not recommending to the patients.
Sure. Thank you for your comments. So now we have got many novel targets in the era of TNBC. That is the antibody drug conjugates, right from sacituzumab or ladiratuzumab. The immunotherapies, as we know, Atizo, Pembro, and Durva are on its way with the AKT inhibitors like iptasertib or capivasertib, or the AR inhibitors which we are also using along with the PARP inhibitors in nowadays schedules. Apart from those novel chemotherapy agents which have been already been approved and which we are using, like anthracycline, taxanes, platinums, or microtubule inhibitors, whether erlotinib or vinorelbine, along with the PARP inhibitors and the immunotherapy cascades, which is now available along with the ADC drug conjugate. So with this brief introduction, I'll come back to a case. It's a 40-year female who with a past history of TNBC. She was earlier treated with 4 cycles of AC followed by 4 cycles of paclitaxel, something 16 months back, and now presented with liver mets and bone mets. So I will get back to Dr. Sujay first. So Dr. Sujay, what will be your approach in this case? What will you want to get the test done, or what will you ask first for in this case?
Two things I would like to do. I would like to get a biopsy done to confirm whether the hormone receptor status remains the same, although the chances of a change of the hormone receptor is around 15 to 20%. Then if it is confirmed that to be TNBC, I would also like to do a PDL1 CPS testing, and simultaneously a germline BRCA would also be requested.
Sure. So in even in the TNBC cases, if it is a pre-TNBC, you are still planning to do a biopsy, or it's only for the hormone receptor positive or HER2 positive cases?
So if it was a prior TNBC, I would all the more like to get a biopsy done, because if the current disease is in any way hormone receptor positive, it will add to my treatment options. So yes, I tend to do a biopsy in a patient on recurrence.
Sure.
For a TNBC.
Dr. Sunil, your comments on this? Are you completely agree with?
Yes, Dr. Amit, I agree with Dr. Sujay. I would also like to do, would like to consider rebiopsy for this patient, and also regarding the molecular test, BRCA testing, as well as PDL1 expression, and if patient is willing, can offer NGS in view of other markers like NTRK and PI3K. So I will do that test. Also confirm the family history. Anyways, we are doing BRCA testing, but your question was what will you like to ask? So I would like to ask in detail regarding the family history.
Great. So regarding the PDL1 testing, which test are you going to order in your clinical practice? So what do you want to do in your clinical practice? Whether you want to go for SP142 or 22C3
So
or any other test?
22C3 I would like to go ahead.
Okay. Dr. Rajit, are you also doing 22C3 in this type of patient, or you ask any panel anyways to be confirming PDL1?
So frankly, I don't believe that in TNBC immunotherapy, the data is convincing enough. I have only given it to one of my patients. I am not convinced, so I am not able to convince my patients. So if in case I am planning, I do mostly SP142 for my patients, or you can either do DACO also. But I am not comfortable using immunotherapy for my patients of TNBC.
Dr. Nagendra, what are you doing in your practice?
Right. So now this is the debatable point. The point here is that we know that atezolizumab nab-paclitaxel, which was approved in the trial, later on the regulatory approval was withdrawn. Since then, we have changed our practice. We are trying to do DACO 22C3 more because the pembrolizumab data is much more mature. But as of now, I do agree with Dr. Rajit why he's telling that immunotherapy is not that much convincing. The data is there in TNBC because these patients only, if we have to carefully select those patients who are on the higher PDL1 score, then only we can do justice with patients. Otherwise, out of 10 patients, if we have used 6 to 7 will not respond to pembrolizumab also. This is what I've seen, even if they are having higher PDL1. It is fitting the criteria of the drug. But atezolizumab nab-paclitaxel is withdrawn. Now, there's no doubt we are not up for it. But pembrolizumab, yes, it is approved, and then we are using also for those patients who are having a higher PDL1. And as far as your question, which platform you are using, answer is I'm using DACO 22C3 wherever possible.
Great. So what is the, we see in the PDL1 expression, that is SP142 is approved for atezo and 22C3 for pembro. Otherwise, the 263 was for GI and head neck cancers. So it's basically the FDA approval is based on this companion diagnostic. But at present scenario, what we see, if one test is positive with one method, it may mostly be positive with the others. So it is not in clinical practice, one can go with either ends of them as per the recent advices. So back to Sujay. So if this patient is having a PDL1 positivity and BRCA negative, so what regime are you going to give to this patient post 15 months of relapse on AC and taxane? And it's a affordable PDL1 positive patient.
I would look at the PDL1 scoring per se. It should be not just more than 1. If it is more than 10, then probably I would be more inclined in using pembro. And right now, I'm not
Sujay,
so
what is the
convinced
practice in TMH as of now for TNBC?
to check whether the CPA score is indeed more than 10 or not. If it is more than 10, and if the patient, of course, again should be an affording one, then yes, as a part of informed decision, we do offer pembrolizumab.
And in what line of treatment do you prefer it? First line or second line?
We will offer it in the earlier line itself, because later on down the lines, the patient performance status as well as the
So with or without chemo?
with chemo, of course.
Okay.
So, and what chemo medicine are you going to prefer, Dr. Sujay?
It's either a platinum or a taxane, depending upon what prior therapies the patient has received.
Sure. So, Dr. Sunil, does the time of last taxane matters to you? That if a patient is responding within 5 months, or if it's responding at late as more than a year or so?
Yes, if patient relapses early, I will tend to change the partner of platinum. Like I would like to use Jayprabha along with pembrolizumab. In this patient, if there is no residual toxicity, definitely we can use paclitaxel along with pembrolizumab if CPS is more than 10.
Or a single agent taxane to if it's not a bulky, vigorous disease which is going on, aggressive disease to be said. So in the basically the for that ISO it was that the IMPassion 130 trial which has shown that if the patient who have not received any treatment in metastatic TNBC and have given nab-paclitaxel, they have shown an improvement, and this improvement has been carried forward even to the OS benefit. But something it happened with that with 131 when paclitaxel was used as against nab-paclitaxel, this benefit was lost, and the explanation of this discordance is unclear. So I'll get back to Dr. Rajit for this. So what do you think, Dr. Rajit, is this difference in IMPassion 130 and 31 that paclitaxel, nab-paclitaxel worked and paclitaxel doesn't work with atizo?
So as I said before that I answered your previous question also, I am not convinced regarding the IO data. So we all know that the indication is also withdrawn in the US. So there is some explanation that probably nab-paclitaxel works better in TNBC as compared to paclitaxel. But I don't know the answer why it is working with nab-pacli and not with pacli. So
Sure.
I don't know. I
Also,
don't use it.
Yeah.
some would say in the paclitaxel group, that is 131, the steroid may have counterbalanced the immunotherapy effects.
True. Dr. Nagendra, would you like to comment?
I do agree what Dr. Sujay just mentioned, that it is with or without steroids, right? That's the difference. What happened, why this benefit was not there in IMPassion 131 and it was there in 130. So that's why the regulatory approval was withdrawn. I want to listen from my other co-panelists also what was their reason. If they can explain why this difference was there.
Yeah, the most common reason is the same, that is the use of the steroids that might have been affected in this group of patients, and that's why atizo might have not any benefit. So the next came the keynote 355 trial, 355 trial, which shows that either nab-pacli, pacli or gemcitabine was used with or without with pembrolizumab. So they have also shown with the CPS score of more than 10, definitely in that group there is a maximum benefit, which we see the PFS of something 9.7 months versus 5.6 months in those group of patients. And thereafter the pembrolizumab got approved in this group of patients. So if a patient have got a previous taxane which is less than 12 months, one may go for gemcarbo or a platinum in that group of patients. So this is how it varies. So this was just IMPassion 130, which shows an improvement initially. I'll skip these analysis. And the keynote 355, which also showed a clear-cut benefit in CPS more than 10, and even with CPS 1, though it is found to be favoring pembro and plus chemo in this group of patients. So regarding the BRCA gene testing, which is the one now everyone is, I think so is doing in, especially in ovary and breast. So Dr. Rajit, sir, are you doing this testing in all patients?
Yes, for triple negative, I am at least trying to push all my patients get the BRCA germline testing done.
Only BRCA, or are you also adding the HRD panel or HRR in those?
So frankly, if I don't know how will I interpret the result, then I don't push for HRD, because in ovary at least I know if HRD is positive, what to do next. So in breast, I don't know if HRD comes out to be positive, how to interpret the data. So I am just doing germline BRCA for TNBC patients.
And in ovary, are you doing
I'm
both
doing HRD? I am doing HRD in ovary whenever possible.
So, Dr. Nagendra, are you having a similar practice or any difference?
I do agree with Dr. Rajit, because germline data is very much mature, right? We are having drug approval for that. But I'm not pushing patients for HRD. HRD, majority times I'm pushing for those patients who are in ovary cancer, and HRR only for prostate cancer I'll be looking for. But for triple negative, I'll be restricting the testing to BRCA testing, germline especially.
So Dr. Sujay, same practice at your and TMH also?
BRCA, yes. As I understand, I do not practice ovary that much, but as I understand from the internal discussion is that HRD testing itself has an issue. What should be the appropriate cutoff point, and also with or without HRD, the benefit has been seen even in those patients who have been HRD negative. So HRD is not that commonly practiced or advised. I mean, it will be very, very uncommon for us to advise HRD, but BRCA is.
So true, mostly because this the myriad choice which have done the HRD, and still what we are, the labs are saying that they have authenticated their data and they have compared with myriad, and now they are bringing it in our practice. So this is what Medgenome and others comment to us. So back to Dr. Sunil. So this patient, if is having a BRCA mutation positive in this metastatic TNBC, when you will give chemo to this patient, or you will going to change it to a PARP inhibitor?
So I would like to start with platinum-based chemotherapy for this patient upfront, and would like to use PARP inhibitor in later.
So this patient, if I will say, has received during her initial treatment with ACA and taxane, and now have relapsed with a BRCA mutation positive. So, Dr. Nagendra, so are you convinced with this, Dr.
So
Sunil?
I am convinced that the patient is platinum sensitive, but I have not used upfront olaparib, and still I would tend to give Pacli carbo and then use olaparib.
That's great. That's the common practice. So, Dr. Nagendra, are you practicing the same way?
I do agree with Dr. Sunil. So, for those patients who are BRCA carriers with previous exposure to chemotherapy in neoadjuvant or adjuvant setting, the PARP inhibitor can be considered as a neoadjuvant treatment, but it's a great recommendation. Although chemotherapy is acceptable, but particularly for those who are PD-L1 positive and whom chemotherapy plus immune checkpoint inhibitors is also an alternate measure. But I do agree with Dr. Sunil. Chemotherapy, if you start and later on you want to reserve it for PARP inhibitors, that also is a viable option. But the only thing is we have to select the patient carefully, depending on the financial implications, because PARP inhibitors are costly drugs. So we have to think so many things, not only scientific data, it's the patient's pocket also which decides many times.
Yes. So, Dr. Ajit, you are not practicing immunotherapy, I know. Are you practicing PARP inhibitor in breast cancer?
Yes, PARP inhibitors in metastatic setting after a platinum-based chemotherapy, and in adjuvant there is data of 1 year maintenance, so you can give after completing the planned chemotherapy in high-risk setting in BRCA positive. Metastatic definitely not as a single agent, but maybe as a maintenance, definitely yes, or in second or in subsequent lines of therapy.
So means after all the lines are exhausted, then in that the last resort, are you going to use the PARP inhibitor or initial also?
Yeah, so not in first line, but maybe in second line or beyond, I think you can use it.
So
Sujay, how is the practice at TMH right now regarding to PARP inhibitors?
Second line or later in the advanced setting.
Yeah. One more thing I want to add here.
Yeah, sure.
Whenever appropriate, we'll try to enroll this patient in pivotal trial, if at all any is going on. That's the first thing we should discuss. And if that is not there, then we should discuss regarding the affordability part and reserve PARP for later on use. Otherwise, if the patients are affordable, then can be considered as first line also. This is the way I look at it.
Great. So, are you having any trial for PARP inhibitor at your center, in which the patient can be enrolled?
In Medanta, Gurgaon, right now it's not there, but I think Rajiv Gandhi one is going on.
Okay, that's great. So I will skip the toxicity profile. So just skip change in a question. If a 45-year woman who has received a similar treatment and now she has got both BRCA and PD-L1 negative, and now she has presented something around after 15 months of the initial period. So Dr. Sunil, so what are you going to plan at this point of time to this patient?
So I would like to plan either Pacli carbo or Gemcis. Both are equal options. Would like to use platinum in combination with taxane or gemcitabine.
So are you constantly using a combination regime, or a single agent is also sufficient if the patient doesn't have a high volume disease in this case?
I think in TNBC, I tend to use platinum. The responses are good. So that is the reason I would like to use the combination.
So Dr. Nagendra, how are you practicing? A single agent or a combination in this group of patients? Or it's a volume based on volume of the disease?
So whenever we are dealing with the metastatic setting, three things we are going to check. First thing, what is the prior agent which were used in the adjuvant setting or neoadjuvant setting? Number one. Second thing is whether the patient is having a germline BRCA there or not. And third point is whether the PD-L1 expression is there or not. Fourth one, you can think whether the patient is in visual crisis or what is the volume of the disease or burden of the disease. Based on that, our treatment is going to, or chemotherapy have to be, we have to choose accordingly. Regarding your question, whether you will go for a single agent chemotherapy or a combination, either can be done. But only thing is, right now there is no prospective controlled trial which have picked up that if we use single agent, they will be superior than doublet, or doublet is inferior to single. So that is on the clinical settings you can take a decision. But decision has to be taken on these three angles. This is the way I look at it. So if the patient has been exposed to 4-AC and 4-paclitaxel in adjuvant setting, I will be using gemcitabine and platinum because I will be surprising the cancer with a newer drug with newer mechanism of action.
That's great. So Sujay, are you agree with that or any change?
Yeah, I agree. Like it has been a traditional practice to use a two-drug gem carbo or a pacli carbo combination, but of late, more and more, I have been finding too much of cytopenias with this platinum gem combination. So recently, I've just started to give some of my patients who are not in too much of visceral burden as a single agent platinum, and also to check the GFR by doing a DTP renogram rather than the traditional formula, and then choosing the dose of my carboplatin in the subsequent cycles to see how much I am able to keep them on the platinum agent. Because with gem carbo, by the fourth, fifth cycle, the patients
Sujay,
have
what is
so
the
much
maximum dose of carboplatin that you use?
Hardly patients go like 7, even though 700, 750 is the dose that comes. These patients are likely to go into cytopenias. I do not cross 600 in the metastatic setting.
That's mostly what the maximum dose is 750, which we hardly go, might be depending on the patient's physique and everything. The same.
Can I make
Dr. Rajit, are you convinced with using single agent carboplatin in this state of the patient? Or you are also gem carbo or a pacli carbo you want to plan in this patient? I think so.
You will have to ask that question again. He just joined back.
Okay. Dr. Rajit, are you there?
Yeah, I am back. I missed his answer.
Yeah, I am just asking ki Dr. Sujay has told he is now practicing single agent carboplatin in most of the patients. So are you convinced with using a single agent carboplatin in this patient, or you will be going back to gem carbo or a pacli carbo regime for this patient?
So for the question, for the patient that you have mentioned, so we need to understand what was the it was given as adjuvant, not as NACT. So usually single agent can be given if the disease volume is low. You have data that adding a doublet does not add to any survival benefit. But to some unknown reason, my practice is to give combination because we have learned it that way, probably.
That's
that is the because of the normal practice that we have been doing. But lately, I have been just trying few patients with single agent.
So if the patient is not fit enough, then I give a single agent. But if the patient is fit, because TNBC usually comes back with a high disease volume only.
Dr. Amit, can I make a comment here?
Yeah, sure.
Yeah. So the usual practice for gem carbo protocol, which we have learned from Sudeep sir, is to utilize gem carbo AUC2 dose. So definitely, if platelets are on the lower side on the day 8, that means it is close to 1 lakh only, 1,05,000, 1,10,000. We tend to skip carboplatin on that day. So that is what we usually practice. And I completely agree. We have also started using DTPA GFR in most of our patients who are either underweight or overweight to estimate the dose, because the dose tends to be overestimated in these patients because of the low muscle mass. Also, those patients who are overweight, we don't get exact details based on. So wherever Cockcroft-Gault equation is unable to give us correct dose, definitely we try to incorporate DTPA GFR in our practice, which is very readily available. Apart from this, one more comment. At our center, there is an upcoming trial of PD-L1 inhibitor, So ociperlimab, which is a TIGIT inhibitor in combination with tislelizumab versus pembrolizumab in patients who are PD-L1 positive. So this trial is going to start in our center very recent in next few months. So we'll be enrolling all our patients into that. Presently, we are enrolling all our patients into the study where we are doing BRCA testing of these patients free of cost as a result of participation. So I think participation in clinical trials remains the best way to manage our patients, and utilizing correct dose of carboplatin is very, very important, as highlighted by Dr. Sujay in really.
Thanks for the inputs. We might be sending patient to you for enrollment. You have to share the inclusion criteria. Which patients do you want to get enrolled in that? Yes, great. So this we have already discussed regarding the duration of the treatment. If it's less, then how to go. So regarding different drugs, so I think so. I will get back to the PARP inhibitors. The other query is, regarding this molecule, eribulin. So Dr. Nagendra, your thoughts on eribulin. So when are you introducing for the management of breast cancer? So this is the most promoted drug nowadays. So in which line are you planning to use it? In the initial first or second line, or later in the fourth or fifth line are you planning to use eribulin in your clinical practice?
Correct. So eribulin is a wonderful drug, and majority of patients are responding to this. So many times what I use is first line based on that I told you what are the prior agents used, germline, BRCA, and third PD-L1. Over a period of time, the patient progresses, then eribulin is a viable option which we are using because it works beautifully in our patients, and majority of patients are tolerating it very well.
Okay, Dr. Rajit, your comments on how do you use eribulin?
I am again not a very big fan of eribulin because my choice of sequencing is AC, taxanes, gemcarbo, capecitabine, and if BRCA1 positive, then PARP inhibitor. So mine, it is usually third or fourth line. So during that time, patient is also fed up with the treatment, or he's not fit enough for, or she's not fit enough for any treatment. So I hardly use eribulin in my clinical practice.
Okay, that's great. Sure. Sujay, how are you using this drug?
My thoughts are same as Dr. Rajit's. It is usually after anthracycline, taxane, platinum, and cape that if the patient is still fit enough to receive, then yeah, eribulin.
Basically, the data regarding eribulin is that it works also in the first line very good, and even in the fifth line, it is going to work. So even if you are using in the last line, this drug is going to show some response, and it at least. So might be, but the recent data is showing if you are using it earlier also, there is a much better, as Dr. Nagendra say, there is a better PFS and OS in this group of patients. So still in my practice too, I am mostly using not if the patient is affordable, I give them this option. But if they are not taking upfront, I keep it this molecule for third line or fourth line. Akhil, are you agreeing with this?
Somewhat different opinion from my side again. So we have analyzed the data of TMH Mumbai also. The 70 patient data is under publication. I and Tanmay had analyzed under Jyoti ma'am, and it is under the process of publication. So we had got some very good responses, and that was not confined only to TNBC. It was even for the hormone receptor positive patient. That is a different from the usual dictum, number one. Second point, if you keep it in the last line, fifth or sixth line, definitely the patients are not going to have good PFS. That we all know. Any drug, if employed in later lines, is not going to give good outcomes. So the most important thing to utilize eribulin, though it has somewhat different mechanism of action from taxane, but if I see the patient had responded well to taxanes previously or had received adjuvant taxane and had recurrence after a significant time, I am happy to utilize eribulin in such setting. But here again, someone can ask, taxane might have also worked equally well. But what have been my experience? Utilizing another drug like eribulin gives much more benefit. And now generic eribulin is also available. The cost is not so high. That is why we are able to utilize this drug in a more and more number of patients. At Varanasi also, we have now series of 60 plus patients. At TMH Mumbai, we had the data of 70 patients in last 5 years. At Varanasi, in last 2 years, we have utilized in 60 plus patients already. And we will be publishing our data of this center as well very shortly. One more point. There is now another upcoming trial at our center of combination of eribulin with PARP inhibitor, and that study will be starting in next 2 months as well. So it seems that eribulin might be combined with some other drugs where there is already some phase 2 studies already published for the same. So I tried to utilize some drugs when already the patient is not so myelosuppressed, so that combination can be used. But again, carboplatin I try to keep in front than eribulin in most of my patients, because we know carboplatin has very good responses. So after carboplatin, I try to utilize in the
Akhil, what line do you give eribulin?
post carboplatin. So if patient received
so before capecitabine.
Before capecitabine, correct. If patient has received, if patient is metastatic upfront, most of the time you utilize paclitaxel, not paclitaxel alone. So, and the next line utilizing EC or AC, then third line again eribulin. If patient has received EC or AC first line, second line taxane, then third line gem carbo is the usual choice, then fourth line eribulin. This is the usual practice. If carboplatin has been utilized in the first line itself, then definitely gemcitabine option is usually not there. So we keep it above.
Yes, great comment. So surely what we have in recent time, it has been changed that eribulin is come to the front. Earlier, 2 years back, we are using it as the third or fourth line. But nowadays, it's we generally give the patient this option of using it in the first line or second line, and that the cost has come down. Even the original molecule cost has to come down in recent times for eribulin.
Only point here is that if we are using it in later line, we know that eribulin is used in 1.4 milligram per day, day 1, day 8. We have to use attenuated doses. Otherwise, upfront, because patient has been exposed to anthracycline, patient has been exposed to taxane, platinum, capecitabine also, then majority of patients will be having neutropenia. Eribulin, 82% of patients can have neutropenia and anemia also as a most common complication. So we have to use attenuated doses majority of the time when you're using in fourth or fifth line.
That's true. So comments well taken regarding this. So just capecitabine versus eribulin. So there was a data regarding this capecitabine versus eribulin, and eribulin was found to be better. Now this drug is also coming in picture, is that sacituzumab govitecan. So I think so, Dr. Akhil, you don't have a trial for this at present?
Not yet.
Other trial which has been in recent days, datopotamab deruxtecan. Might be this trial is available in Delhi at a few centers. People have started enrolling patients for this also.
Yes, this trial is available in Delhi, and it will be coming to our center as well in the next 3 months. But sacituzumab is not yet come. It is not available in India. Compassionate access also cost very high, $110,000. It's very costly, $11,000 drug for 1 dose. So it's very costly. We have utilized sacituzumab also imported for 1 patient already.
Okay, so I'll just now want to get over, but a few last comments. So Dr. Rajat, so this is a new concept of HER2 low is now coming in picture. So though we haven't adopted in our clinical practices, so are you convinced with this TNBC HER2 low and to start treatment for this group of patients? This HER2 low.
Yeah, so I think the results look very promising. I have not gone through the data, even the latest ASCO 2022, this data has been shown and published. So I think that it looks very promising. So since I have not read it, I may not be able to comment.
Dr. Nagender, do you want to comment?
Only thing is it has not yet come to the pen of the doctors. Obviously, the data is promising and amazing, and we are looking forward for it. How to know, like you mentioned, these are potential future strategies. So as of now, it is premature to comment about this. Maybe in future, we will be discussing more on this matter.
Sure. Dr. Sujay, your last comments?
Yeah, I mean, any additional option is always welcome, but it's a promising result. Let's see.
Yeah, okay, thanks. Dr. Sunil, are you there?
I agree with all panelists.
That's great. So thank you all, everyone for joining this panel discussion and making it a very fruitful, and it's mostly what we see in our natural practice, what we are doing. It's a practical discussion only. We haven't gone those bookish ways, and also Akhil gave the input how to sequence, and what is in TNBC, we are just sequencing our drugs to give the maximum benefit. So right from whether it's a PD-L1 positive or a breakup mutation positive or all things negative, and how to impact the use of eribulin, at least in nowadays good drug. So this is how we are going against these all things. with this, I'll thank you everyone, and back to Mishra sir for his final comment.
Thank you, Dr. Amit. Very nicely you explained each and everything by you and our esteemed panelists. I think with this we can finish the session and over to organizers for the further questions.
So I'll now request Professor Sambasivaiha sir to chair the next session and introduce our next speaker, Dr. Akhil, for his talk.
Amit, yeah, it's a very good discussion on TNBC. I really enjoyed thoroughly. And now there is about this topic. Of course, the PIK3 inhibitors is an exciting arena in the hormone receptor positive postmenopausal women, and there are FDA approvals too. And there are some baskets of the agents approved. And I will come, Dr. Kapoor, Associate Professor, TMH Varanasi, to guide us and enlighten us on the advances in the PIK3 mutation landscape. Okay.
Thank you, sir. Thank you for the kind introduction and guiding us. So I will be starting with my talk on picking the right strategy for our patients who are hormone receptor positive, HER2 negative with PIK3CA mutation. So definitely, we have learned that this is an option for our patients. Initially, we were very concerned about the toxicities, but I will be covering my practical aspects and the practical experiences as well, so that this talk doesn't remain just a unilateral talk. These are the disclaimers. We all know now that PIK3CA mutation is very common in our patients, and at least 4 out of 10 patients will have PIK3CA mutation in our practice. So definitely, it should be tested in our patients, because there is an option to utilize a targeted treatment which can be used. There was an option to utilize exemestane everolimus. Yes, we have utilized the same. However, the main problem with that component is that the toxicities of the treatment. Again, we need to see why we need to do PIK3CA mutation. We all know PIK3CA mutation is a common indicator of poorer prognosis, and there has been significant data for the same as well. Metastatic breast cancer patients, genomic analysis data of 60-50 patients, and even a meta-analysis of 1900 plus patients, which clearly stated that presence of PIK3CA mutation is itself a marker of poor prognosis and worse overall outcomes. So that remains the key. It is not only a predictive marker, it is also a prognostic marker. So that is important. We have learned this from Sudipta sir, what is a predictive marker, what is a prognostic marker, and this marker has both the aspects. So PIK3CA mutation status, how it is acting as a poor prognostic marker? Because it leads to increased cellular proliferation and thus helping in tumorigenesis and also helping in the endocrine resistant pathway activation, leading to poorer prognosis and outcomes of our patients. So this alpelisib drug is actually PIK3CA alpha mutant specific inhibitor. What is the advantage of this alpha specific inhibition? That it doesn't have collateral damage on beta, gamma, and delta pathways of PIK3. So that is why this has selective inhibition, and it can overcome resistant to endocrine-based treatment pathways. So when to test, how to test, and why to test. Why to test already discussed. How to test? Yes, there are options of utilizing QIAGEN TheraScreen, which is now a companion diagnostic marker, and it is very readily available. It is not very costly as well. It is cheap, and also Novartis gives us free coupons to utilize this test in our practice. It is freely can be done free of cost on the tissue. When doing on the blood-based, yes, blood-based reports are also reliable, and most of the time they have good concordance, and blood-based is also an option. When to test? One point which needs to be understood is that this is a stable mutation and not a dynamic mutation. Lung cancer, we know most of the mutations are dynamic and it is difficult to get hold of particular mutation in real time. That is why you cannot not act on a particular mutation which we have detected 2 years back. But here, what is the difference? That is a completely stable mutation. That is why you can rely on this test, which was even done 2 years back. You will know, even if you repeat this test, you will get the same mutation again. And in Indian patients, exon 20 mutation 1047 is H1047 is the most common. And in our patients, we have done testing of more than 250 plus patients of PIK3CA. We'll be publishing our data also shortly. And the mutation rate is again matching. It is close to 35% in our scenario. And 70% patients had H1047 in our group. And this data is going to be published shortly. So yes, this is what we have discussed till now. And here, most of the time, we utilize this drug in combination with fulvestrant, and this is the trial as well. And this is preferred treatment option as per the NCCN recommendations as well. It can be done either on the tumor tissue or liquid biopsy. Why liquid biopsy? In real practice, again, if we see when we are where we have tested 250 plus patients, we realize out of 250, 178 patients were however tested on the blood. Why? Because this is very common practice when we find that a patient who was hormone receptor positive and later received curative treatment, later progressed and progressed only in the bones. Then we go and have most of the time any reliable tissue where we can do the sampling, because if we biopsy the bone, there will be chances of high grade degeneration of the DNA during the process of the decalcification. That is why we usually don't rely on the bone biopsies for finding our patients. However, if the patient has a visceral disease, definitely it is recommended to test, because we know patients who are progressing in the visceral sites are also chance of having triple negative breast cancer at progression. So it becomes imperative to test with biopsy to change in the biomarker status and also to get a tissue which can be tested. So it serves a dual status. So moving further ahead, this is the SOLAR-1 trial, and we are all aware of this trial now very well. One point I would like to highlight, it is not only for post-menopausal women, even men were a part of this trial. And we see a lot of patients with male breast cancer. That study, we are doing a prospective compilation of the data again. Male breast cancer, this is again.
Dr. Akhil, your slides are not moving.
Dr. Amit, can you see moving slides or not?
No, it's not moving. I thought you are just basically.
Okay.
So you have to just.
So yes. Though I was not utilizing any slides till now, but now I will. Yeah. So most of the things which I told was not on the slides.
Yeah.
Let's see if you are able to see the slide. Not yet.
Yeah, we have slide is visible. You can just move and let us know.
Let's see. It is SOLAR-1 slide.
Yeah, it's SOLAR-1. Fine. Yeah, it's going on. Carry on.
Okay.
Please.
So this is the SOLAR-1 slide. The post-menopausal women and males were also a part of this trial. More than 18 years old, randomized to receive PIVIKTO 300 milligram daily plus fulvestrant versus fulvestrant alone with placebo. And primary endpoint was progression-free survival, which was investigator-initiated. So if we see the data of progression-free survival, it is 5.7 months versus 11 months. So clear-cut, close to doubling of the progression-free survival with addition of this drug, which makes our life easier. And definitely, it seems that the patients are responding well to this treatment, and all the subgroups are getting benefit. One point again here I would like to highlight: there are some patients who respond very poorly to previous CDK4/6 inhibitors, and even those patients who have responded poorly to CDK4/6 have progressed very rapidly on CDK4. Alpelisib has good outcomes even in those patients, and that subgroup analysis has also been presented in the recent SABCS last year. So that is again a point which I wanted to highlight, which might not be present on these slides, but that is worth notable in real practice. So this makes us very confident. All the patients are getting benefit. If we see the response rates, more than double the response rate, 16% versus 36%. That is the ballpark figure which I want to highlight to our patients. Patient might not understand PFS. Patient understand response rate in the real practice. That is why I tend to highlight the response rates while counseling my patients. Also, if we see the waterfall plot, this is a very beautiful way to look at the drug responses. Though the partial response rates, you can see it is not always in present, but still you can see 76% patients are down staging of the tumor, which makes our patient definitely symptom burden reduction is very important, and that makes our patient feel much better, and symptom burden reduction is very useful. Another advantage, dosing, yes, 300 milligrams. So it is available in the formulation of 150 and 100, and we can utilize both of the same. And you can see the dose reduction is usually 300 to 250, then coming to 200. But definitely there is an option to utilize alternative dosing as well. We will discuss this during our panel discussion as well. So what are the adverse effects which you will think about while initiating a patient on PIVIKTO? So all patients will develop some amount of hyperglycemia. This is for sure, because this is inhibiting a pathway which is directly involved in insulin pathway. So there will be insulin resistance initially, which will be there, and that will peak from day 11 or day 12 to day 1 month. So that is the most important thing which should be kept in mind while initiating our patients. HbA1c, it should be well controlled, it should be below 8. If it is more than 6, you need to be very, very cautious and need to optimize the sugar levels so that maximum benefit is attained. The GI side effects, yes, it can cause some amount of GI side effects, including diarrhea. Some patients might get stomatitis as well, but these are not so common in our practice. The most important is hyperglycemia. Second most important is skin rash. But again, skin rash has been implicated in the Western data to be more than 30%. And even this study subjected to utilization of drugs which are anti-allergic for all the patients as a prophylactic treatment. But in our patients, what we see, a lot significantly lower risk of skin rashes and allergic events. So this is not a big problem in our settings. Yes, hyperglycemia is a problem, and you need to have significant experience of managing the same. And also, if you are not willing to take that headache, you can definitely involve your physician. We have a dedicated physician at our hospital who is involved in even in the trials regarding alpelisib, and we take care of the same with the help of our physician who is expert in managing this. And also, continuous blood glucose monitoring is a concept which has now rapidly coming into India, and for that also our center is a random study site for the same. So moving further ahead, yes, this is what we have already seen. It is an on-target adverse effect. So expect in all your patients and manage the same. How to manage? This is actually very, very subjective and depends on your individual patient. One thing, always ask patient to maintain a drug diary and glucose diary. In the same diary, on the first day when you are starting alpelisib, or even before starting alpelisib, ask your patients. And this should, even alpelisib, what I think should be started in patients who are well educated or at least have good caregiver who is able to take care of the glucose measurements, so that you can have glucose charts which can be made. In our hospital, we have created a drug diary for all our diabetic patients, and we are going to start a diabeto oncology clinic very shortly. And presently, also we are utilizing a drug diary, also a sugar diary, so in which all the patients record their sugar levels in the fasting state in the morning, and it might be done in the alternate day initially, but whenever the readings are on higher side, utilize it daily and ask the patients to record the same. If the sugars levels go beyond 300, we ask the patient to hold the drug and report to us immediately, so that the patient does not go into diabetic ketoacidosis, because we have seen one patient who had gone into diabetic ketoacidosis, but thankfully the patient contacted us very early, and the patient could be salvaged without much issues. So yes, we need to be careful. And definitely utilizing metformin is the basic thing, but utilizing other drugs such as dapagliflozin. Dapagliflozin is a SGLT2 inhibitor, and we know with dapagliflozin, patients will develop hyperglucosuria. So there will be glucose excretion directly into the urine, and that will make patients probable sensitive to developing UTI. So that is another point which should be noted. And when patients are taking dapagliflozin, you should educate your patients. If they have done a urine test, they will be seeing 2+ or 3+ glucose, though the sugar levels might be well controlled. And the peripheral physicians might not be able to understand the same, why the sugar levels are normal, but urine glucose is showing very high. So this is the thing which should be noted and intervention. So we are having again a trial of alpelisib in patients who are having impaired glucose tolerance. So that trial is also ongoing at our center. So these are the various aspects. So fasting blood sugars and HbA1c should be monitored. And if HbA1c, the standard monitoring is 3 monthly, but we can utilize in patients who had higher HbA1c at the baseline. After optimizing, we can do it at 6 weeks as well. And this is about rash, which we have already discussed. And there is a quality of life data as well. You can clearly see with this data, it is clear that quality of life was not compromised with the utilization of alpelisib, and that should be always kept into the mind. And with time also, you can clearly see quality of life remains good. And this is the data which suggests that even there was some improvement in physical and emotional functioning using alpelisib. Why this is happening? Yes, when the patients have good disease control, automatically some quality of life parameters will improve, and that is what reflected in this outcomes. So definitely, if symptom management is good, patients will have good quality of life, and this is what I have highlighted. Just to summarize, PIK3CA mutations are present in 40% of our patients. In our data set, it was 35%, and it doubles the median progression-free survival and more than double the response rates from 16% to 35%. Safety, it has hyperglycemia, yes, but we need to learn how to manage them and also involve your physician or diabetologist in the management of same. And this is very important, and it maintains the good quality of life in the patients. And it also delays the time to initiation of chemotherapy. So these things are really important for a patient. With this, I would like to stop here, and we can take some questions during the panel discussion with the permission of the chairperson.
Okay. Doctor, there are a few questions in the chat box. Dr. Anshul has asked regarding the liquid biopsy for PIK3CA mutation. So what's the sensitivity of it? So are you convinced with doing liquid biopsy in all patients, or you need a...
So what we feel, liquid biopsy we have utilized in a significant huge number of patients. When Dr. Anshul was here at TMH Varanasi, he also had seen that we are doing a significant number of patients blood-based testing only. Why? The tissue remains an issue in this hormone receptor positive patient, which I have already covered in my talk. But I'm very convinced about the outcomes which the data reports of the blood-based testing. When we utilize blood-based testing and it comes negative, ideally you should be repeating it on a tissue. But if the tissue is available, why would have we done on blood? Because blood-based test required some cost to be paid, while Novartis offers free coupon for patients doing on tissue. That is why our preference is to do on tissue when tissue is available. When tissue is not available, we go ahead with blood-based. If any time at the patient progresses and we are able to get a good tissue, then we can repeat on tissue. But still, I am very comfortable in doing on blood, and the results are good. And this 35% includes 80% patients who were tested on blood and not tissue. So this data is matching with the data of close to 40%, which is the Western data.
So you are utilizing the free coupons for this blood-based testing also?
Blood-based coupon will be there, but there will be some cost, 1,500 to 2,100 cost will be there.
That's great. And there's any opinion regarding P10 testing also?
So it is a part of a trial which is also started our center. Drugs like capivasertib and ipatasertib are on the horizon. 30% patients will have P10 mutations as well. But this till the time we know that these drugs are able to benefit our patients, I cannot offer this as outside our trial, any trial, but definitely as a part of the trial, we have started to do the same. Again, the problem is that the patient should have good quality tissue so that P10 testing can be performed. So NGS will be done in those patients as a part of the trial.
So Dr. Akhil, if there is a PIK3 mutation along with this PIK3CA mutation, so as I understand the literature, that the effectivity of alpelisib is reduced in those cases.
Can you repeat, Dr. Anshul?
I heard the question.
If a patient is having a P10 mutation along with the PIK3CA mutation, the alpelisib will not work.
So the actual explanation is that if P10 mutation is added, P10 mutated patients have very poor outcomes. This is for sure. Already we know that PIK3CA mutation is having worse outcomes, and if alpelisib is not used, it remains very poor. If P10 mutation is added, it actually the pathway through which the alpelisib is working, there is inhibition in that pathway. That is why there is definitely chances of reduced benefit, but definitely it is if P10 trial is not available, we can still offer our patients.
Thank you. So now we will move to our last session, that is the panel discussion by Dr. Akhil Kapoor on management of advanced hormone receptor positive breast cancer. And the panelists for this are Dr. Somnath Roy from TMC Kolkata, Dr. Anshul Agarwal from Kiran Hospital Surat, Dr. Anuj Gupta from TMH Varanasi, and Dr. Vignesh Sansa from TMH Varanasi. So I'll request Dr. Akhil to please start the panel.
So since we are running out of time, I will try to keep it very short and sweet so that we can discuss just the real perspectives and we don't spend much time on other aspects. So are the slides visible till now?
Yeah, slides are visible, please.
Yes. So I'll be not utilizing too much of slides. It would be kept directly on our real experiences. So to take comments from our panelists, let's start with Dr. Anshul. Dr. Anshul, if you see a patient is having significant pleural effusion, hormone receptor, and you did a pleural tapping and also did a ICD and pleurodesis was done. Patient had hormone receptor positive, 8, HER2 negative. The patient is 55 years old. The patient has disease in as a part of pleural effusion, breast lesion, and 3 lesions in liver as well. Apart from this, there are multiple bony lesions. So what are the options in your mind, and what treatment would you offer to your patient?
So this is the hormone receptor positive case. So in this case, pleural effusion because the patient isn't having a pleural effusion. So what was the amount of the pleural effusion?
Patient required. Patient required.
So she is on ICDT, so we need a rapid shrinkage of the lesion. So I will start with the chemotherapy, and I will prefer to go ahead with anthracycline based chemotherapy.
Okay, so here is the cliché, and which we will discuss, and we'll take opinion from other various panelists. Dr. Anuj, would you would have separate different approach, or you would have similar?
If the patient, as the patient, am I audible?
Yes, please go ahead.
As the pleural effusion has been drained and the pleurodesis has been done, and the organ functions are not at that the patient is not in visceral crisis, I would I would go ahead with hormone therapy along with CDK4/6 inhibitor.
Okay, so your comment well taken. So there are options to utilize since the patient already had effusion which was drained, and now the patient does not have any visceral crisis for sake, and the patient is a candidate of starting on CDK4/6 plus hormonal therapy as well. So that is an option, but definitely it depends on the resources. Sometimes when CDK4/6 cannot be initiated, we will be more comfortable in utilizing chemotherapy. Definitely, these are the things which I completely agree.
Agree with.
Yeah. So moving with the next question, Dr. Somnath. You have also a great experience of utilizing CDK4/6 inhibitors. You have the option of utilizing the 3 drugs. Palbociclib, the patent is going off, and the generic will be coming very shortly. Then the option of utilizing ribociclib, then the option of utilizing abemaciclib. How do you select between the 3? That is a very common question. It has been asked to us so many times. Let's get some words from your side.
Yeah, thanks, Akhil, for wondering this nice discussion. So all of us know these upfront, these all 3 are available and all are approved in the first line setting in metastatic breast cancer, hormone receptor positive. But if you know, if patient is definitely in primary endocrine resistance, definitely the subgroup was showed palbociclib is better in this category of patient. If patient is an active CNS disease, the subgroup is showed alpelisib is better in this category of patient. Otherwise, rest of all we can offer ribociclib plus CDK4/6 plus AI or any aromatase inhibitor in these settings. So all of us know the among the 3s, the overall survival data is almost quite matching for others, but there is no head-to-head comparison and directly which is better, which is not better. But we extrapolate the data from the comparator arm was the AI in all these 3 trials. And if it is postmenopausal with a definitely primary upfront metastatic disease, my options in this case will be the ribociclib plus AI.
Okay. So definitely these are some of the important points which we keep in our mind. Dr. Pipnesh, do you want to add anything, or you have a similar ways, or you want to add anything?
Yeah, similar only, but like those patients with liver mets, sometimes they used to have GI symptoms. So in that case, abemaciclib will be causing GI symptoms. So I will avoid that, and otherwise same.
Okay. So that is a point which can be considered. However, let me share my way how I select. First thing, palbociclib, it causes significant amount of neutropenia, though it doesn't cause much febrile neutropenia. I utilize palbociclib very rarely. Out of 100 patients which we have used, I'm just giving a rough percentage. We utilize less than 10% patients on palbociclib. 70% patients will go on ribociclib, because in our experience that has been a drug which has been the most tolerable. But definitely you need to be cautious about QTC prolongation in some of the patients, especially the patients who are having rhythm disturbances. Keep aware of the same, and also keep a close watch on QTC in the initial 2 to 3 months. After 3 months, it doesn't cause much significant problems, but in the first 3 months, do ECG monthly for first 3 months. That is what I practice. Thirdly, abemaciclib. Yes, there is data to suggest abemaciclib is a good drug, especially in patients with poor prognostic factors. What are these poor prognostic factors? Number 1, patient is ER positive but PR negative. Second, patient is young patients, less than 40 years of age. Yes, these patients are having aggressive disease. Number 3, the patients who are having significant amount of visceral disease. These patients, I personally prefer utilizing drugs like abemaciclib. However, ribociclib is also a good idea. Patients with brain mets, yes, data is for abemaciclib only, and abemaciclib crosses into the brain much better than other drugs, and that is why the usual preference is to utilize abemaciclib in those patients. That is how we select. Definitely, efficacy-wise seems to be somewhat similar, toxicity-wise somewhat different. So in some poor prognostic group, prefer abemaciclib. Abemaciclib is a drug which has a single agent activity, and it can be utilized in some patients, even a single agent, which we know already. But other drugs don't have any single agent activity. Even we had a discussion a few days back. Patients who have progressed on other CDK4/6, and there's no other option to utilize other chemotherapy or other drugs, you can still utilize abemaciclib, and you will get again a 4 to 6 months of PFS. So that can be considered in selected patients. However, if you say which is the most tolerated drug, yes, it is ribociclib in our practice. 70% patients out of 100 will hormone receptor positive will go with ribociclib. That is what we have seen.
In what percent, Dr. Akhil, just to interrupt. So with abemaciclib, are you seeing transaminitis more as compared to others?
I have not seen. I have also utilized in the patients with liver mets, and I have presented that case at multiple places. The patient had a young patient of 25 years. The patient had multiple liver mets, though bilirubin was not high, but AST/ALT was high, and I have utilized abemaciclib in that patient as well. And patient had really good response, and transaminitis actually settled, which was due to disease. So I do not usually see transaminitis with the abemaciclib, and even diarrhea, which we know from the usual pattern, usual reports that abemaciclib causes a lot amount of diarrhea because of its CDK9 inhibition. That is also not very common in my experience. We have the experience of more than 20 patients now for abemaciclib, more than 70 patients on ribociclib, and 20 to 30 patients on palbociclib. So it is somewhat different from the usual literature which we see.
One thing I just want to add, Akhil, if patient is definitely is a primary endocrine resistance disease with a post AI.
That is a point which we missed. Correct.
Yeah, in that case, I think the subgroup data of Mona Lisa is Palvo is better than other three. That is another point to me.
In primary endocrine, abema is better than other drugs, correct?
Yeah.
Yes. That is another point which is important, and that is another point which we keep in our routine, because we know abemaciclib is the most potent CDK4/6 out of the three, though outcomes remain somewhat similar. And abemaciclib has shown efficacy even in the adjuvant setting, IDFS benefit in the early breast cancer, which we have seen, but other drugs, palbociclib, have failed to show the same. And also recently there is a data which was presented in this ASCO 22. Palbociclib failed to get overall survival benefit over letrozole alone. So we now have some data that palbociclib is unable to get OS benefit. However, ribociclib has clearly shown overall survival benefit, which was just presented in the beginning of the meeting by Dr. Anuj. So these are remarks. Dr. Anuj, do you agree with this statement?
Yes, completely agree. In the ASCO 22, it was presented that, as I told, palbociclib didn't show any OS benefit, significant or statistically significant overall benefit, and the other two have shown. So that both the other two are much should be preferred over palbociclib, I think.
Okay. So we have discussed the perspective regarding PIK3CA during my talk itself, and I had tried to cover most of the things. If there was any comment or question, we'll discuss here. One comment which I would like to get from our panelists, Dr. Anshul, your experience with everolimus exemestane in any patients, and how has been the tolerance to the patients?
So everolimus exemestane I have used only in Tata Memorial Hospital, and so I faced a lot of mucositis in those cases.
Okay. So yes, everolimus causes significant.
And 1 or 2 patients had a pneumonitis also.
Okay. So yes, these are the important adverse effects: pneumonitis and mucositis. That means stomatitis. And all patients who are on everolimus should be given dexa gargle from the day one. We don't utilize everolimus exemestane too much in our practice now, because we have seen we have now various other options, including alpelisib, which can be offered. And though we utilize everolimus with lenvatinib in patients with RCC, and there also we utilize significant VC mucositis and stomatitis, but that is significantly reduced with the utilization of dexa gargles. So that is a routine practice to give dexa gargle from day one to the patients. Also, don't miss to give clotrimazole lozenges to these patients who are utilizing dexa gargles, because these may develop oral thrush. So these are some of the important points which should be considered in the routine practice. So in the best interest of time, I think we can stop here. And if there is any other burning question in the mind of anyone, we can take it here, or else we can stop here.
So just to brief up or to summarize, so how would you treat a case of a hormone receptor positive metastatic breast cancer? So what are your initial choice if the patient is affordable for anything, and in the second line and third line at least?
So the first point, first see whether the patient needs CDK4/6 or not. I will take the help of one of my panelists here, Dr. Vipnesh. Any particular subset where you would like to avoid utilizing?
Yeah, patients who are very old, like more than 65, 70-year-old, and only bone mets, in those patients we can skip as they will have a they do good with only AI only. So in that patient, we can skip CDK4 inhibitors.
Yes, yes. Which based on clinical scenario, can you give some example? One example of clinical scenario?
like a 70-year-old lady who has only a few bone mets, suppose say in a few 3 to 4 mets in the vertebra and one in sternum skull. So and she has a PS of like 2 in or maybe 3 also and then 2. In that case, we can just give her an AI. She will do well with that only, and we will be able to avoid the toxicity of the CDK4 inhibitors, as it can cause some significant of fatigue and neutropenia also. So in this, like this patient who are like this group, in that I can avoid CDK4/6.
Completely agree. Very well summarized by Dr. Vipinesh, that a patient, elderly patient with 8/8 ERPR, patient with limited bone mets, there that we know that that patient is going to do very well for 25 months to up to 3 years or 4 years, even on letrozole alone. So why to give toxicity of any other drug? So this particular subset, utilize letrozole alone. That is number one. Second, you choose among the three. Even I have utilized ribociclib in patient with visceral crisis, and we have got good results. Out of 7 patients in the visceral crisis, 4 patients had very good response, and the patient was out of visceral crisis, which includes significant of transaminitis in the patients, and bilirubin level of 3+. The patient was salvaged with the utilization of CDK4/6. The CDK4/6 inhibitors, if utilized in the correct way in the full dose, they are able to start action within 10 to 14 days. And even chemotherapy, these patients are PS3, even with PS3 or 4, it becomes difficult to give chemotherapy in some patients. It remains up to the physician to choose between CDK4/6 versus chemotherapy, but we know the patients with higher bilirubin are also difficult to give paclitaxel full doses. So here it is very difficult, and it depends on the experience of the physician and the confidence of the physician. If you are confident to go ahead with chemotherapy only, go ahead with the same. But I will say, yes, now there is upcoming data for utilizing CDK4/6 even in patient with CDK4/6, and that should be kept in your back of mind. And utilizing all the 3 drugs, yes, but we tend to utilize more of ribociclib and some amount of abemaciclib. I have practically stopped using palbociclib because of the reasons which were discussed, and in poor prognostic subgroups, I prefer using abemaciclib. Always send a PIK3CA mutation at the baseline itself. Don't, so that you have a ready report with the known. And also, if you get a PIK3CA mutation, you know that these patients are going to do somewhat poorer, and you will need to be very vigilant. For example, in our routine practice, we do scans very rarely, 6 monthly, or even somewhat we tend to do only chest X-ray and USG in our routine practice, the patients who are metastatic with limited sites of disease. But in patients who are PIK3CA mutant, we know these patients are going to be somewhat worse. In those, be vigilant, do a scans like a patient on chemotherapy every 3 monthly. But in other patients, you might avoid utilizing doing a 3 monthly scans, and can do away with 6 monthly scans, or even a yearly scan in some of the patients who have limited burden of the disease. So these were my initial thoughts.
There's one question. My question is that what about the SOAP trial in which we have combined fulvestrant with another AI? So if many of the patients are not affordable for CDK4/6 inhibitor and all this alpelisib, so is there any benefit in place of a single AI, a combination of fulvestrant plus AI?
So if you are unable to utilize either PIK3CA inhibitor throughout in the lifetime of the patient, you cannot utilize CDK4/6 inhibitor throughout the lifetime of the patient, then you can utilize this agent, this combination. It will have some benefit over a single agent alone. But what happens even in patients who are not affordable for CDK4/6, with the utilization of various support programs, in next 2 to 3 months, when we start patients on letrozole alone, in 2 to 3 months, the patient get support of various programs, even the relief funds through which the patient gets significant financial support, then we can start CDK4/6. This is what we really do in our practice. That is why I don't end the options of utilizing both fulvestrant and AI in my practice. But yes, it can be used when you cannot utilize either CDK4/6, when you cannot utilize either PIK3CA inhibitor in your practice.
Thanks, Dr. Akhil, and all the panelists for the great discussion about the hormone receptor positive metastatic advanced cancer. So with this, we are now reaching the end of our session, and I just ask Dr. Akhil once again to give a vote of thanks to end this session.
Thank you. It was a really wonderful discussion, and we thoroughly enjoyed the discussions. Both triple negative breast cancer panel was also really well done, and also we have seen great talks by Dr. Anuj as well. So we thank all the participants, all the panelists. We thank our sponsors. A special thanks to Dr. Amit Kumar for toiling very hard, doing all the preparations. Thanks to Suchitra Cancer Care Foundation team for doing the excellent conduction of the meeting. The background work is really important, and this background work has been the topmost, and definitely it is very, very important. Special thanks to the panelists, and we are very hopeful to be able to conduct much great academic discussions throughout our meetings. Dr. Amit, you can add if I.
It's a very thankful to our organizer and our sponsors like Novartis, Medgenome, and Zydus for this session. And a special thanks to the Suchitra Cancer Care Foundation, to Mr. Gautam, and our preparators, Rima, Tanya, and Devesh for their help in this. So with this, we come to an end. Thank you, everyone.
Thank you.